ALS is a progressive lower motor and upper motor nerve degenerating disease. Most patients with ALS die of respiratory complications. Respiratory monitoring is critical, therefore, in these patients. Typically, forced vital capacity less than 50% is an ominous sign. Patients with bulbar predominant disease, however, can't make lip seals. Therefore, using standard pulmonary function tests are difficult to perform in these patients as they get sicker and sicker. However, non-invasive ventilation improves survival in these patients, so it's very important to be able to monitor their ventilatory status. So imaging solutions for ventilation exist, although the present solutions are problematic. CT and MRI are possible candidates for monitoring ventilation. However, they really can't be used for multiple assessments. They are too expensive, they are rare resources, and the radiation dose issues with CT are problematic. So ultrasound is another option for evaluating ventilation. Ultrasound is fast, safe, and easy, and B-mode ultrasound is being used a lot for evaluating lung pathology. However, this is based on artifacts and is qualitative. Another option would be to use Doppler. Spectral Doppler is quantitative. However, the lung motion would be across the beam in general. So that would mean that there would be basically no Doppler shift. So spectral Doppler has a problem in this regard. Power mode would be another way of doing it. However, power mode is basically binary and wouldn't be quantitative. A final option is speckle tracking. Speckle tracking is used for motion evaluation. However, it is difficult to do in the lung. The lung surface is noisy, and the motion that would be evaluated is inherently 2D within the plane of the ultrasound. However, the motion of the lung surface could be 3D or across the beam as well. And finally, if the speckle that you're tracking goes under the ribs, you can no longer track that speckle and therefore can't make the measurement. So instead, we decided to test another method for evaluating motion called decorrelation motion estimation. This is based on matching or comparing A lines or M lines from different time instances. The comparison is made by autocorrelating the A lines or M lines over time. The data is presented as instantaneous one-lag plots. The lower the correlation coefficient, the greater the difference between the lines and the more motion. The motion is presented as decorrelation, which is 1 minus the correlation coefficient. And in some sense, this is similar to B-flow. The metric that we ultimately use for the comparison with the ALS patients is the sum of the first lag decorrelations over 1 second. So this is a plot of decorrelation in a normal subject. The plot is demonstrating the instantaneous decorrelation over time. And you'll notice that the time record is being made in M-mode firings. Most of the slides or graphs in this talk are over M-mode firings. However, that does not affect the metric, which in this case is an average decorrelation of 0.066. This is a low value relative to portions of the lung closer to the diaphragm. You'll notice that the measurements are being made here between the two vertical red lines. These red lines mark the points when the lung motion has basically stopped. So they're defined between either full inspiration to full expiration or full exploration to full inspiration. So that would correspond basically to half a breath. So this is a decorrelation plot in the mid-lung in the same normal subject. You'll notice that the decorrelation is higher in this portion of the lung than in the apex. So there is more motion of the lung surface in the mid-lung than in the apex, consistent with more ventilation occurring in the mid-lung. The measures are again made between the two vertical lines, which corresponds to either inhale to exhale or exhale to inhale. And then when you go to the base, the lung motion increases a lot. The decorrelation is much greater, and so the extent of the motion is greater. You'll notice that the decorrelation between the breaths may not relax to zero. That's just an arbitrary standoff, so the measurements are made taking that into account. So any individual measurement is very noisy because the lung surface is very noisy. However, if you can, because of this metric, you can make many A mode measurements or M mode measurements and average them. And then even though any individual position on the lung surface may have a decorrelation metric which is very noisy, if you average them, and this is an average of 40 M lines, you get really nice curves. So this is a two-dimensional plot showing the simultaneous decorrelation of 40 M lines. The M lines are plotted along the vertical axis, and time is plotted along the horizontal axis. White, or the whiter the pixel, the more rapid the motion or the higher the decorrelation, and the darker the pixel, the lower the motion. You'll notice that this particular plot is over what would be close to one breath, meaning that there is high decorrelation going to low decorrelation, back to high decorrelation, and back to low decorrelation. So that would be like inspiration to expiration, then expiration to inspiration. If you look along any of the particular M lines, you'll notice that the decorrelation can be quite noisy. However, if you average over these 40 lines, you can get a much smoother curve. The study was an IRB approved study in which all the subjects provided informed consent. There were 10 subjects with ALS, but we did 11 examinations. One subject had 2 studies. The ultrasound machine uses a Philips Epic 7G. We used an L12-5 transducer. We selected regions along the left and right lung surfaces. The patient was asked to take a deep breath, and then we averaged the left and right lung results. We then compared these average results to the forced vital capacity, which is presented in percentage, which is based on the patient's age and body habitus. The evaluations were made based on a p-value of 0.05. So this is a decorrelation plot in a patient who has a forced vital capacity of 66%. The measured portion of the breath is between the 2 red lines, and the amount of decorrelation in this case is relatively low. And this is a patient which is more normal, and you can see the forced vital capacity was 109%, so he was actually breathing more than the average person would be expected at his or her estimated body weight and age. And the decorrelation rate is higher, or the total decorrelation is higher. So this is a plot showing the linear regression comparing total sum decorrelation in 1 second and the forced vital capacity. The slope is significant meaning that there is a relationship between these two parameters. So in conclusion, decorrelation motion estimate is a way of estimating lung surface motion. It's easy, it's fast, it's quantitative, it's inherently 3D, meaning the decorrelation changes in different directions, although the decorrelation rate changes because of the beam shape. So that would have to be compensated for, but in fact does work. And it works on noisy data, as I showed you, because you can get many, many measurements. One potential application for this metric would be to evaluate ventilator performance during the present COVID-19 pandemic. This would be particularly useful in circumstances where a ventilator is being shared between two patients. The use would be to monitor positive end expiratory pressure, or PEEP, in each patient. Presently, it would be very difficult to evaluate positive end expiratory pressure in each patient separately using the presently used metrics. However, using decorrelation, it would be possible to make this evaluation in each patient separately. Thank you very much.